right. So, again, Nathan Mueller, Colorado State University. I have the honor of chairing this session. So, 15 minutes per speaker again, and I'll be relatively strict with the time so we make sure we get our caffeine. So the first speaker is Jane Baldwin from UCI.
All right. Hi. As Nathan just mentioned, my name is Jane Baldwin. I'm an assistant professor of Earth System Science at University of California, Irvine, also adjunct at Lamont, where I was a postdoc. So it's great to be back at Columbia. I'm a climate modeler, atmospheric scientist by training, but today I'm going to talk mostly about health, and I'll try to explain why I started thinking about this. I had this ambitious title for my talk because I wasn't exactly sure how much time I'd have projecting the health impacts of heat and changing climate challenges and opportunities. I'm going to focus on a specific part of this, which is whether debates about the role of humidity and heat health outcomes and how they might be leading to substantial uncertainties in our projection of heat in a changing climate. This is work that was made possible by very broad interdisciplinary collaboration with epidemiologists, climate scientists, public health researchers, et cetera, including Chris Ebi. So I'm very grateful to our keynote speaker for her help. Okay, so this is not news to any of you if you've been paying attention during this workshop, but at extremely high levels of wet bulb temperature, the human body cannot cool itself, leading to heat stroke and death. Wet bulb temperature is, you can think of it basically as a combination of dry bulb temperature and humidity. Just to give some sense of it, if you covered a dry bulb temperature thermometer in a wet cloth and spun it around, the temperature that thermometer would come to would be its wet bulb temperature. So it includes some cooling due to evaporation. And importantly, wet bulb temperature increases with dry bulb temperature and humidity. So it's basically a proxy of both combinations of temperature and humidity that are very relevant to thermodynamic effects on the human body. It's sort of like heat index. Now, why humidity is really important to account for is because about 75% of cooling of the human body is modulated by sweat evaporation. The human body constantly is producing metabolic heat, and we need to be able to dispel that heat to the environment. Otherwise, we literally cook ourselves and die, as my physiologist collaborator says. So if humidity levels get very high, that shuts down this evaporative mechanism of cooling and can in turn lead to death. So starting around 2010, there's been this series of climate studies arguing for severe health risks from rising wet bulb temperatures. And when these studies started to come out, I was doing research on heat waves, just using dry bulb temperatures, and got very interested in them. I think this discussion really starts with this awesome paper that came out in 2010, An Adaptability Limit to Climate Change Due to Heat Stress by Sherwood and Huber, where they posit that 35 degrees C wet bulb temperature is a limit to human survivability, and they look at exceedances of that threshold with climate change, looking to levels of warming that are beyond, at this point, what's realistic for us to experience. But they do begin to see these exceedances and argue that there'd be parts of the Earth that we literally could not live on. After this study came out, there are a variety of follow-up studies that look at particular regions or look at observations and see that it's been very rare to exceed 35-degree wet bulb in the observed record. And there are many other studies that I don't have time to mention here, but in essence, there's this flurry of kind of climate science excitement around using wet bulb temperature, partially because it has this direct tie to impacts, but also I think there's this element of, as climate scientists, we're trained to think about physics, and there's something very physical about wet bulb temperature and its role in cooling of the human body that's appealing. If you want to dive deeper into this literature, I recommend this review by Buzan and Huber as a good starting point. So I was seeing this literature at the time as a result of a different project. I was also reading the epidemiological literature. And I started to get very, very confused because I saw that epidemiologists and physiologists seemed to really not agree on the role of humidity in heat health outcomes. In essence, physiologists think humidity is really important for heat strain, and epidemiologists think, it doesn't really seem to matter that much. And to understand how they reach these different conclusions, I need to say something about how these two different types of health researchers do their work. So physiologists do things like putting an individual human in a heat chamber and measuring the body's response, or doing kind of a detailed modeling of the energy balance of the human body. So it's a focus on the human body and its various physiological mechanisms. And when they do these studies, they find that humidity is a critical driver of heat stress. If humidity is higher, it's harder for the human body to cool itself. And at very high levels of temperature and humidity, that can lead to elevation of core body temperature, which is very dangerous. In contrast, epidemiologists study associations between health outcome numbers and populations across time with weather data. So this is an example from an epidemiological study where there's a time series of maximum daily temperature compared to a time series of the total number of daily deaths. And they basically use statistical regression approaches to look at the association between these environmental variables and the health outcome, whether it's mortality or morbidity. And most of these studies find that humidity really isn't necessary to predict heat health outcomes. They add it into their association model and find it really doesn't make much of a difference. We do just as well predicting mortality just from temperature and some other correlates, and if we add in humidity, it really doesn't make a difference, which in essence means maybe humidity doesn't matter. So to really drive home this point about what the epidemiologists find, a state-of-the-art epidemiological study came out in now 2019. I say state-of-the-art because, to my knowledge, it's still to say that through the most data at this problem. And they looked at daily mortality and weather in 445 cities in 24 countries. And this is a direct quote from the paper. They say the absence of a positive association of humidity with mortality in summer in this large multinational study is counter to expectations from physiologic studies, though consistent with previous epidemiologic studies finding little evidence for improved prediction by heat indices. Heat indices here, we're talking about something like heat index or wet bulb temperature, a combination of temperature and humidity. So again, there's this divergence in what the physiologists are finding and what the epidemiologists are finding. And if you dive into the details, it's kind of interesting, and I can't explain this, but I'm just putting it here for your interest. They find, this is a lagged model, and so they look at the effect of an environmental variable on the day of mortality's measurement, but also in the days prior. And they find humidity on the day of does, in fact, increase mortality, but on the days prior, it net decreases mortality. So overall, the effect of humidity is neutral, or in fact, actually slightly negative, they find, for mortality. So I'm run into this issue, and as a climate scientist who's very interested in the human impacts of climate change, I got frustrated or productively confused depending on how you look at it. So if the health researchers do not agree on the role of humidity and heat health outcomes, what on earth should we do to project future heat-related illness? So I'm going to schematically illustrate why I think this really matters. So with climate change, we see temperature increasing, and also following the Clausius-Clapeyron relationship, in general, we see specific humidity increasing as well in a different pattern than temperature alone. And of course, there's spatial variability to this. If you're farther inland, you're going to see different humidity changes, but in general, humidity is increasing with climate change. If you take the epidemiologist results at face value, you might model future mortality as a function of temperature alone. And indeed, there are studies that do this. In contrast, if you take the physiologist results at face value, you model mortality as a function of both temperature and humidity. And again, this is just a schematic to illustrate the point. I should figure out a way to put hard numbers on this, but again, it's just an illustration for now. We might expect very different trajectories of mortality going into the future depending on which of these realities is the truth. Another reason why humidity, mattering or not, is important is it affects the pattern across space of change in heat stress we expect. So this is a plot adapted from a paper by Nick Lutzko, where he's looking in change in a moist heat stress metric across many different CMIT models with global warming. And this moist heat stress metric, you can think of like wet bulb temperature. So we see greater increases in this moist heat stress metric or wet bulb temperature in the tropics than the extratropics. And if you look at the constituent components that contribute to this pattern, dry bulb temperature actually has polar amplified changes. In contrast, specific humidity has tropics amplified changes. And what I'm showing is the pattern correlations between moist heat stress and temperature and moist heat stress and humidity. And you can see this moist heat stress response is very strongly affected by the pattern of specific humidity change, which means that the pattern across space of future changes in heat-related illness we'd expect is going to be very strongly affected by whether humidity matters. And it, in my opinion, has potential equity implications with climate change, given the different economic status of countries in the tropics versus extratropics in a gross sense. Finally, whether humidity matters or not would also influence appropriate climate change adaptations, whether you're thinking about fans, self-dousing, green space, any of those interventions that Chris or others have talked about. Your quantification of their effectiveness would be different if you're focused on metrics like dry bulb temperature versus wet bulb temperature, heat index, et cetera. So I ran into this issue, and at first I was like, okay, great, I'm going to solve it. And then I started talking to different researchers I was friends with about this goal of reconciling the differing viewpoints regarding humidity to ensure robust projections of heat health outcomes with global warming. So this is the big goal. And I quickly realized there are many, many different possible explanations for this issue. So what we did as an interdisciplinary team covering epidemiology, physiology, biometeorology, basically all these different fields relevant to heat, is put forward hypotheses for the physiology, epidemiology disconnect around humidity. And I only have a few minutes left, but I'm going to try to blaze through a couple of our key hypotheses, but want to note that if you're interested in seeing kind of more systematically all the different hypotheses we put forward, please look at our paper that came out in Environmental Health Perspectives last year. Okay, so first, the limited extent of the epidemiological data may bias the discernible role of humidity. This is a map showing extremes of wet bulb temperature in the historical record. You can see that wet bulb temperature is generally higher in the tropics, no big surprise there. But where we have epidemiological data shown in blue is primarily in the extratropics. So we simply haven't sampled these really high levels of temperature and humidity perhaps enough. Additionally, the places where we tend to have epidemiological data are also places that have high correlation between temperature and humidity, which might make it difficult to disentangle the separate roles of these two environmental variables. We have limited epidemiological data in low and middle income countries where people are likely more vulnerable, and also the weather data we tend to use is from airports. So there could be something complicated about neglecting urban heat islands and indoor climate that matters. It's also possible that something with the limited temporal resolution of the data matters. The data used in epidemiological studies is generally daily mean maximum or minimum temperature paired with daily mean humidity. However, there are complexities of temperature and humidity and their changes on the sub-daily cycle. So if you have high levels of temperature and humidity, you'd expect the atmosphere to start to convect. This then could lead temperature to decrease. So it's possible in real time extremely high temperature and humidity are unlikely to occur simultaneously for long duration, and daily data may be obfuscating something here. I'm a little less convinced by this now, but as a meteorologist by training, I wanted to mention it. Finally, there are also physiological reasons that could explain the epidemiological results. This is a figure that Ollie J. created based on some of his physiological models. We have humidity on the x-axis, temperature on the y-axis, and what's shown in gray are the hottest recorded hourly temperature and accompanying relative humidity from a bunch of city weather stations. These thresholds are thresholds for a man and woman, a sedentary man and woman. Again, generally when people die in the heat, they're often alone in their house, sedentary. And you'd have to exceed these thresholds, like move to the upper right beyond them, for additional increments in humidity to matter for heat strain. And this is because, to a certain point, the human body is really good at compensating for changes in humidity. So it's possible, again, we really just haven't sampled in the historical record these levels of temperature and humidity that matter. So these are all the reasons that we hypothesize. I didn't have time to discuss it here, but it's possible that epidemiological studies are mostly drawing on cardiovascular and respiratory deaths, which are fundamentally different than heat stroke in some ways. Happy to talk about that more if people want. To conclude, health researchers find diverging results regarding the role of humidity. Physiologists think humidity matters. Epidemiologists aren't so sure. Whether humidity matters would have a large impact on both the spatial pattern and degree of heat health risk with global warming. We put forward various hypotheses, could be on the epidemiological data side, could be something to do with physiological factors. I hope I've successfully galvanized all of you to go forth and test these hypotheses and resolve this debate by the next time I'm at a workshop at Columbia. So thank you.
All right, right on time. Thank you, Jane. So please find Jane for questions during the coffee break. We'll go ahead and move on. Our next speaker is Chris Callahan from Stanford.
Thanks for the introduction, and thanks to Jane for interrupting this series of Chris's giving talks here. Perfect. Big green button. Perfect. All right, thanks so much, everyone. Thanks for being here. Thanks for having me. I'm excited to talk about our work trying to understand the mortality impacts of very unprecedented or unobserved extreme heat events, like Chicago in '95, which is what's there. I don't need to convince you that heat really matters from a health perspective. The previous two talks have done this, but I do want to point out that we have climate projections of heat and heat-related deaths that say that they will go up by more than 300% by mid-century, at least according to the Lancet Countdown report. And the folks that have done this from the perspective of economic impacts and sort of monetization and valuation for decision-making, the social cost of carbon and other metrics like that, have pointed out that heat-related mortality might be the single costliest impact that we have currently quantified from a sort of economic valuation perspective. The implication of this is that it's really, really important for us to understand what methodologies go into these kinds of projections, where their strengths and weaknesses are, and how they might sort of project onto the most unprecedented or unobserved extreme heat events. So I want to give you a brief overview of how we know this conclusion and how we've come to it. Jane did a lot of this already, so thanks to her for setting this up. The typical approach here is to parameterize some relationship between temperature and mortality using observed data. So this is the epidemiological approach, where, for example, to walk through this somewhat scary equation for a moment, we could imagine parameterizing or statistically modeling the mortality rate in a location. Think of this as like the mortality rate in a US county in a certain month in a certain year, as a function of a bunch of baseline factors. So you can think of seasonality in deaths that's unrelated to temperature, location-specific factors, long-term trends in healthcare access, all of these other factors, and then some nonlinear function of temperature. We know that mortality tends to go up at the cold and the high end, and so there's some complex curve associated with temperature and changes in mortality risk. And you can parameterize this in many, many different ways. You can include many different things in your temperature variable and so on, but this is the basic approach using observational data on all of these factors. This is now a very widely used approach. We've come up with a bunch of different examples of these kinds of curves where you can see this sort of classic J shape of slightly rising mortality at the cold end and then very strong increases in mortality at the high end as you hit high temperatures, both done by studies, both by folks in the sort of economic side of things and epidemiological. And this is now widely used in a wide array of studies to both attribute previous mortality risk to climate change historically and to project into the future for increases in heat-related deaths going forward. This is now a critical input into the social cost of carbon, which is used in federal government decision-making and regulatory analysis, benefit cost analysis by federal agencies, and so on. So understanding how these projections kind of come to be is important. But there's a critical challenge here, which is that the past and the future have and will confront us with extreme heat events that are far beyond the observational range. We've seen this in the past, and it's likely to increase further in the future. I'm showing an example of a heat wave over Chicago that came from an ensemble boosting approach where Eric Fisher and a bunch of colleagues reinitialized a climate model a bunch of times and produced a range of plausible heat waves that have not yet been observed, but are physically plausible at current warming levels. And the point here is that the temperature anomaly you see over Chicago on the left at present levels of global warming is basically double what we saw in 1995. So an extremely high impact heat wave that is plausible yet unobserved. How do our models trained on observations handle events that are so far beyond that observational range? The question we're asking is how we handle such extrapolation. Can we be confident in the impacts of unobserved or unprecedented events, precisely given the way that we use observations to come to these conclusions? And so the research question that I'll be talking about for the next few moments is, can these empirical and observationally trained models quantify mortality from unprecedented extreme heat? This is, to some degree, an unanswerable question in truth, but the approach I want to show you is a basically out-of-sample test that we did to assess the skill of these empirical models on a few historical heat case studies. So I'm going to walk through Chicago in 95, France in 2003, and the Pacific Northwest in 2021. All of these are familiar to all of us, but they were very high impact heat waves. And so they serve as useful case studies for understanding how well we could have predicted the mortality toll from those events. So we did a few things. We estimated these temperature mortality response functions using data on temperature and mortality in each of these locations. We did this prior to each of these events with data leading up to each event, but not including the event. So this is an out-of-sample test where these functions don't see the event in question. We then predicted what those functions would tell us the heat-related mortality from each event would be. And then we compared that to some quote-unquote true value of heat-related mortality, either from recorded heat deaths on things like death certificates or excess deaths calculations where you look at the number of deaths above baseline factors for that time of year and that location, which we typically think of as actually slightly more reliable given that heat-related deaths tend to be undercounted. So here are the three case studies, at least from a physical perspective. Again, I'm going to move through this quickly because you all don't need much convincing that these things were really bad. The analysis we did was to estimate these curves of temperature and mortality change for each of these locations, Chicago, France, and Washington State, using data from each location specifically. So this accounts for all the adaptations and acclimatization that might have occurred in each location leading up to the event. We then looked at what the true heat-related mortality for each of these three extreme heat events was. Again, a sort of unknowable, number, but canonically we think of Chicago as killing about 700 people, France about 15,000, and Washington a little over 440, if you believe the excess deaths numbers. So the question then is, what do these temperature mortality response functions tell us the mortality would have been during those events? And unfortunately, they way underestimate the mortality that actually occurred. So this function would tell us that about 45 people died from the heat in Chicago, relative to about 700. This function would tell us in France that about 3,000 people died compared to a quote-unquote true number of 15,000. And in Washington, the predicted number is around 34. Remember that the blue and the yellow curves are not based on that parameterization in the top row. They are independent estimates that we can now compare. But what this implies is that these functions, both historically and in the future, undershoot the death toll of extreme heat events by anywhere from 5 to 10 times. For folks that are interested in humidity, Jane talked a lot about this. We do not see that humidity is responsible for this gap. So if you do this calculation again with wet bulb instead of dry bulb, which I'd done before, I'm just doing this for Chicago and Washington because calculating wet bulb takes a while, and I didn't have the time to do this before the conference for the globe, so I just have it for the US at the moment. But I can tell you that if you include wet bulb temperature instead, the number goes up for Chicago for a little bit because canonically that was a sort of humid heat wave. For Washington, the number is actually negative, which just implies that that event had wet bulb below climatology, which I think is consistent with our intuition that that was a relatively dry event. But in either case, this does not appear to close this gap in our predictive skill. A few other things are worth noting. We do find that this underestimate occurs for a few other heat waves that we looked at the death toll from. There was one in Philadelphia in '93 that killed about 100 people. I think we estimated like 5 deaths from our parameterization. Spain in 2003, Maricopa County in Arizona in 2023, and so on. So this appears to be a somewhat generalizable phenomenon where the most high-impact heat waves are poorly predicted out of sample by the methods that are incredibly prominent in the field of heat mortality projection. A few things that may be responsible for this that we're playing around with. We are using monthly or annual mortality data at times in this work because that's what's available. The question is, can we recover daily scale effects with that data? Preliminary evidence suggests yes, as long as you basically aggregate the temperature data in the right way, as long as you're sort of careful with the polynomial transformation you're doing, you can recover the effect sizes associated with daily effects in your monthly or annual data, as long as you are careful to not wash that out in the temperature signal. If folks are interested in that, I'm happy to talk about it, but we've done some tests to suggest that we think we're doing okay in this regard. Nighttime temperatures often, they're not in our results in the sense that we're not explicitly considering hot nights as distinct from hot days. This could matter. There is some evidence that the effects of nighttime temperatures are not substantially greater than the effects of hot days on mortality, although I think this is to some degree an open empirical question, and so this may play a role here as well, although I'm not convinced it would, multiply our estimates by 10 times, which is what is necessary to close this gap. Similarly, consecutive hot days rather than days distributed more widely throughout a month, for example, again, certainly matters, certainly increases the effect of a given hot day. Again, the existing literature from an epidemiological perspective suggests that this would increase the effect by 10% or less. And so again, it would not multiply our estimates by 10, which is what would be necessary to close that gap. One thing I do want to throw out here is the co-occurrence of air pollution and temperature. This is something that I think we actually have a very poor handle on from the perspective of mortality. Like, what are the compounding effects of air pollution and temperature in terms of their mortality risk change? This is an active area of research for our group, and so I hope that I can come back another time and talk about the work that other really smart scientists at Stanford are doing on this. But I think we don't yet know enough about this to know exactly how much this is playing a role. If you all have other hypotheses, I would love to hear them. We are stuck on this problem a little bit. We legitimately don't know what's going on. But I think that's an important conclusion in and of itself. And so I do want to leave you all with a few takeaways. The first being that our conventional temperature mortality models appear to perform very poorly out of sample when assessing the mortality associated with unprecedented extreme heat events. This, to me, is frankly pretty worrying, because it implies that future extreme heat events, which are likely to exceed historical precedent, may be substantially deadlier than our current projections indicate. At the same time, these projections are critical inputs into decision-making tools, adaptation analysis, risk analysis. And so if we are undershooting the mortality toll from extreme heat, that has huge implications for the rest of climate policy decision-making. Future work has to think about the ways that mortality risk might be amplified during extreme heat events above and beyond many of the non-extreme conditions that are the precise inputs into the data that we use to then characterize the impacts of extreme heat events. So it's possible that our work indicates some potential fundamental mismatch between these conditions that we have to understand better. My contact information is up here. I'm happy to take questions if you've got them.
Thanks, Chris. We have a few minutes for questions if folks want to come to the mics.
Very nice talk, Chris. I was wondering, the projection model you talked about, the outsample projection model with temperature, how much of it takes into account factors like, the air conditioning use, the housing condition, the environmental condition indoors?
Yeah, it's a really important question. And the short answer is that we're using data for a decade or for each event, we're using the data we have for the decade or two right before that event. And so to the best extent we can, we think that we're capturing whatever was present at the time right before that event. And so if there was, a rapid increase in air conditioning penetration in the 10 years before 2003 in France, like that's something we'd capture, although we didn't do that explicitly. So we're not, including an air conditioning variable in the model or anything like that, but we are doing it in such a way that these models are using location-specific and hopefully time-specific data to capture whatever adaptations were present right before that event happened.
So the possibility, I guess the hypothesis you were saying, another thing is that when it's so extreme, that may not be, electricity and all of that, you have air conditioner, may not work.
Exactly.
So
it's totally possible, yes.
So I have two naive remarks which are related to the 2003 heat wave in Western Europe. So for instance, in France, it was shown that the number of people dying during this heat wave was increasing linearly with time. It means that the total numbers of people dying would be quadratic with the duration of the event. So it seems to contradict one of your the conclusion you. So and the other thing is that people specialists of this in France they say that with the measures that have been taken for adaptation and especially a better preparedness of the health system and a better communication towards the public would mean that if the event would occur today, there would be much less people dying.
I think that's absolutely right. I agree with both of those things. The question about duration and sort of compounding mortality, I think is really important. And the stuff I put up at the end there, I think our existing literature tells us something, but this is definitely still an open empirical question. And these are things that we're going to be doing analysis on, to be sure. I also definitely agree that what our analysis does not suggest is that if these events recurred, they would have the same death toll. So I do want to be sort of careful about that and just say that this analysis was done, all of these functions were done with data prior to the event, not following it. So we're just trying to say, given that event at that time, what would we have predicted? But I absolutely think it's important to consider the ways that societies have reacted to those events. And so the future versions of them might not look like the past ones, certainly.
All right, we're going to have to unfortunately cut it off there. Thank you, Chris. The next speaker is Yawen Wang from the University of Hong Kong.
Hello, everyone. I'm Yawen from the University of Hong Kong. I'm very happy to be here to show you my research. It's about the increased health risk under the compound heat and ozone events in Hong Kong. Thank you. We have discussed a lot about the increased temperature and the global warming in these days, and here I also want to highlight the increased ozone pollution in recent years, as well as the compound heat and ozone events. To make things worse, the climate change is expected to lead to more frequent and intense occurrence of the compound events in the future. When we look at the situation in Hong Kong, we can see that the frequency and the duration of the heat event, ozone event, as well as the compound heat and ozone event both increased over the past 2 decades. For the health impact of the heat and ozone exposures, we can see that with the increased temperature and ozone pollution, the health impact may start from discomfort and finally may go to the death. And there will be an increased death risk when the temperature and ozone is very high. For the mortality burden attributed to ozone and heat, from the line chart, we can see that most countries shows a declined mortality burden due to ozone exposure, but in some countries, especially for those middle to low-income countries and low-income countries, the mortality burden attributed to ozone actually increased. From the bar chart, we can see that the heat-related mortality burden also varies across locations. Well, as many studies focus on single exposure, the compound heat and ozone exposure, as well as its health impact, is still unclear. So here, in this study, I would first likely to summarize the evidence of the impact of compound heat and ozone event. And then we'd like to evaluate the mortality risk on the compound event in Hong Kong. And finally, I'd like to summarize the potential methodology challenges and the future research needs. First of all, we did a systematic review. We searched a total of 5 databases and finally included a total of 54 studies. From the 2 bar charts, we can see that the number of the related studies increased in recent years, and most of the studies actually use sub-national level data. And from the spatial distribution map, we can see that more than 10 studies came from China and came from the US, while limited evidence can be found in the Southeast Asian countries and in Africa. To summarize the included studies, we can see more than half of the included studies, they use mortality as health outcomes, while the other studies may also use hospitalizations, emergency department visit, pregnancy loss, or mental health problems, and so on. And for the result, we can see most included studies shows there's an increased health risk under the compound event. And 6 multi-setting studies shows that the risk may have spatial heterogeneity. So then we use Hong Kong data to evaluate the mortality risk under compound heat and ozone events. We use daily mortality data from 2000 to 2021. Actually, we are still considering how to define the compound events, actually. So first of all, we use single-day compound events. It's shown in the top row. It means a day with heat event and ozone event. We can define this day as compound event day. And at the same time, other days will be defined as heat day only, ozone day only, or no event day. Actually, we also want to know if the successive compound events have impact on human health. So we summarized 3 scenarios. For scenario 1, 2 events have overlap, no matter which one occurs first. For the scenario 2 and scenario 3, 2 events will occur within 7 days. We choose 7 days, refer to some of previously published study. And from the red plot, we can see that under some definitions of the compound events, there's an increased mortality risk, especially when we define compound events using daily maximum temperature higher than 33 degrees C and maximum daily 8-hour average ozone level higher than or equal to 160 microgram per cubic meter. Actually, these 2 cutoff values are also considered by the Hong Kong government when they considering issue some heat warning or air pollution warnings. So here we would like to say that in Hong Kong, there's an increased mortality risk under the compound heat and ozone events. So here we would like to discuss some reasons about our findings. First of all, is from the systematic review, we can see that there's a spatial discrepancy of the health impact under the compound event. Some reasons may be due to the location-specific environmental or demographical factors, such as different weather patterns, climate patterns, or cultural backgrounds, and so on. Other reasons may be the statistical issues, such as definitions. Actually, almost every study has its own definitions about the compound heat and ozone event. So we just have difficulty in defining how to put them together. Another one is the confounder issues. The mechanism behind the ozone and heat exposure and health is a little bit a little bit complex. And the most commonly recognized reason is that one exposure could enhance the other's impact on health. So when we combine them together, there's an increased mortality risk. Here I'd like to summarize some limitations in our systematic reviews and our Hong Kong database estimation. In our review, the main limitation is cutoff values, since groups with highest values was regarded as high-level exposure if they also didn't define the high levels. And another limitation is that we only included paper published in English, so evidence in other languages may be missed. Our Hong Kong database estimation, I would like to say the limitation may be the confounder, maybe the confounders. Also, we have tried our best to adjust as much as we can, but we still admit this as a limitation. Another one is we use weather record data from one station, and we assume that data from more weather record stations may be needed. Here, I summarized some methodological challenges pointed by our included studies. The first one is the appropriate study design. Time series study and case crossover study design are commonly used in the health-related studies. But I want to say that well-controlled time series and well-matched case crossover design are recommended. And another challenge is that we need some high-quality exposure data, especially if we have individual exposure data and accounting for the time they spent in various microenvironments. The third challenge is accurate diagnosis and timely reporting of the health outcomes. Based on these methodological challenges, maybe there's some further research needs. The first one is we need to define the compound events more comprehensively, but not use the one-size-fits-all definition. Another one is we need to enhance the study design and enhance the modeling methods. The final one is that we need some location-specific estimations to help to eliminate the unevenly distributed climate change impacts. For the public health significance, actually we have discussed a lot in these days, and here I would like to summarize them into 3 points. The first one is the in-depth understanding of the mechanism behind the compound exposure may help maybe the stakeholders and the government officers to develop some adaptation strategies. And then doing such study may help to mitigate the spatial health inequalities under the compound events. Finally, such study may help to protect the vulnerable groups such as the elderly and the female. Finally, are some measures to reduce the health impact. To reduce the health impact, we need first to understand the mechanism of the compound events, and then we need to raise public awareness and promote some protective behaviors before and during the event. Here, I would like to take the heat-related research as an example. These plots are from the Hong Kong Red Cross. Actually, they have done a lot to reduce the health impact under the extreme heat days. For example, they set up some community cooling centers, and by doing some database analysis, maybe our paper-based research can help them to decide when, where, and how to set up the cooling center due to the limited resources and manpower. Although transferring our paper-based research findings into practice may be a long way to go, but I think we should still on the way to go. And here's some reference, and thank you. Welcome any questions.
All right, we have some time for questions if folks Want to come down?
Hi, Yawen. Thank you for that very nice talk. My name is Peter Crank at the University of Waterloo. And I was wondering, in your study, as you were thinking about heat and ozone, how much of a role does the indoor environment in Hong Kong mitigate the impact of outdoor? We know if you have really good central air conditioning, your ozone levels indoor decouple from outdoor. Do you have a sense in Hong Kong if that actually happens, or is it completely different?
We admit that the indoor and outdoor air pollution levels may be different, but at this stage, I would like to say that we only have station-based records. We also want to, do some individual-based data analysis, but at this stage, sorry to say we don't have such data actually.
Thank you.
Thank you.
Hi.
Hi.
Thank you for your presentation. Yeah, I just wanted to ask about seasonality, whether you consider it in your analysis, like during the summer, spring and autumn, maybe you find some signals in terms of the effect of seasonality. Then secondly, I would like to know whether, I want to know about the statistics of the typologies of what's it called now? The compound event. Maybe you have like 5 scenarios. What's the statistic like? Do you have an idea of maybe 20% occurrence of one of the scenario versus the other? I just wanted to ask about that.
Sorry, I missed your second question.
Okay, so you talked about different scenarios.
Yeah.
Like maybe ozone happen first plus heat, or heat then ozone, and all the various typologies you showed. I just wanted to know, maybe you have just a quick thought about the effect of the proportion of their occurrence, and how that will affect the relative risk results.
Actually, we have analyzed all these 4 scenarios, and this plot just shows the single-day exposure. And we also, for the successive compound events, sorry, I just give a brief discussion. I'll give a brief description. And now I want to say more about that. In the successive compound events, actually, we define the days into 4 groups. The first group is non-even day, and then the second one, the third one, and the fourth one is scenario 1, 2, 3. Actually, we also compared the scenario 1, 2, 3 to non-event days, and the results are more or less similar to the single-day event. Yeah. Thank you.
Okay. Thank you, Yawen.
Thank you.
All right. Our next talk is from Peter Crank at the University of Waterloo.
Good morning, everyone. As you can see, shifting the topic just a bit, but as I'm talking about a subgroup of the population that's often misunderstood and marginalized, I think it's also really important for me to acknowledge that this work specifically was conducted in the Salt River Valley on the ancestral territories of the Akimel Ootham and the Peeposh, who cared for the land prior to Western arrivals. And I also acknowledge that at the University of Waterloo, I currently work on the traditional territory of the neutral Anishinaabe and the Haudenosaunee peoples in what is called the Haldeman Tract, land that was granted to the Six Nations. And then today we are also talking about these issues on the traditional homelands of the Lenni Lenape and the Wappinger peoples. And so thinking about marginalized communities, and that's another marginalized people group that were in spaces that traditionally were held by them. So talking a bit about not just mortality, but morbidity associated with air temperature today. So a brief outline of where we're headed. I'll talk a little bit about why heat matters. I think we're all very much familiar with that at this point, so hopefully can breeze through that one quickly. I'll do a little bit of an explanation on the connections between neuropsychiatry and extreme heat. It's a connection that isn't well understood, both in the science, we have some ideas, but that then is not translated to the general population. So I want to give some space to talk about that. I'll walk through a little bit of the methods. Chris used that in Stanford for the mortality side. So again, I don't have to go into a ton of detail there. And I'll go through our results and some of the implications from that. So briefly, as has already been mentioned, heat is a silent and unnecessary killer. It is also, according to the National Weather Service, the largest weather-related hazard, both in 2023, across a 10-year average, and the climatological average as well. It outstrips the other weather-related hazards, and these numbers, as we've already mentioned, are undercounted. Maricopa County, where Phoenix, Arizona is, had over 600 deaths in 2023, which is 3 times the number that the National Weather Service said happened. We add in what the New York Mayor's Office presented to us on Wednesday, and there's over 300 here in New York City last year. So between Phoenix and New York, we're talking about 5 times the number that is officially listed as the national numbers. So this is an issue, and it goes beyond just heat-related deaths, but also impacts our health and well-being. So a little bit about our neuropsychiatry and extreme heat. What we know already from the literature is that A, heat is a primary weather-related hazard that kills people. We also know that it can negatively impact our human health even before death, such as instances of heat exhaustion and heat-related illnesses. But we also know our mental health is impacted not just by our atmosphere, but also our environment as a whole. And so there's research that is shown, as this diagram here depicts. Literature shows us that physiologically and psychologically, we are both impacted by urban environments as well as heat directly. So this diagram is from an accepted paper in the Journal of Urban Design and Mental Health, where we know that the combination of heat in cities results in increased heat stress and stroke, decreased thermal comfort, as well as respiratory problems. So we can absolutely think about that in the air quality piece, bringing in an additional layer of complexity. But psychologically, we also have hazards at play. I think we can all connect to the personal experience of being overheated and being a little bit more irritable with our loved ones, maybe slightly more aggressive as we're driving down the roads and being annoyed by somebody cutting us off. But it goes beyond just increased aggression and irritability. There is connections for both heat and with urbanization to increased depression and schizophrenia. And one of the things that I would like to focus on is that we've looked at this not just in the US, but also globally. And some of the things that we're identifying through these types of relationships is that the weather is impacting our mental health, and specifically schizophrenia. So schizophrenia is a group within a group of disorders that collectively all act very similarly, such as bipolar disorder and manic depressive disorder. One of the things that we see at the most basic level with these mental health disorders is that they block the neurotransmission of information to specific parts of our brains. The part of the brain that schizophrenia directly impacts is the anterior hypothalamus. And for the rest of us who are not physicians, including myself, that is where our thermoregulatory functions happen in our brain. It's the part of the brain that tells us you're too hot, you need to sweat or drink water. It's the part that tells you to shiver when you're cold. So for individuals with schizophrenia then, their bodies are not telling them to do the things that our bodies, when they're normally functioning, are doing without us even thinking about it. So for individuals with schizophrenia, they're at a higher risk than the general population because they're not going to respond to their bodies the way the rest of us do. For individuals who have the privilege of being able to have medication and be able to afford and take their medication regularly in this space, the good news is that medication works and the neurotransmission starts working again. So their bodies are telling them to sweat. However, one of the main side effects that we see with these medications is that they raise the internal core body temperature. So if the rest of us are sitting at 37 or 38 degrees Celsius core temperatures, they're moving toward 39, possibly even 40 in some instances. So they're already closer to that 43 degree C threshold that was talked about earlier. So regardless of the state of their medication and their condition, these individuals are at a higher risk than the general population. And so what a lot of these studies have looked at is various ways of looking at the weather and the environment around us to assess this. And what I looked at specifically is the one in Arizona, specifically looking at minimum air temperature. Other people, including Nori Samra at Boston University, looked across the US at environment or emergency department visits during the summer months to look at how mental health is being impacted and how people are responding through seeking medical professional attention. She and her team noted that specifically within schizophrenia, you see a somewhat linear increase. That is this one down here. And then for all cumulative response across a wide range of mental health conditions, we see that response. Her team also noted that it's more oftenly occurring with men rather than women, and that it's more prone across the northern tier of the US. I think some of that has to do with the unprecedented nature of some of the heat waves you've seen recently in those parts of the world. But at the same time, we have places that are much hotter than that who are also grappling with this. And we may be presuming something about individuals' acclimatization if we're not considering that as well. So instead of going through into the detail side of the statistical model, I have found this to be particularly helpful in explaining it to the general public and practitioners of the model is simply a function, and your outcome is simply a function of the number of hospitalizations per day for schizophrenia. I did this in Phoenix, Arizona, so across the county in their hospitals. We're going to use a lagged temperature metric from day 0, so day of, going back to the preceding week before to see how temperature over time is influencing it. We have the trend line, so we can keep track of changes over the time period. This was from 2006 to 2014, and we had over 86,000 cases in this model. We account for seasons as well as weekends. If we think about hospitalization visits, those are influenced by things like weekends and holidays. So we accounted for those holidays as well along the way. Okay, so what I'm going to be showing in the next couple of slides are 3 types of results. I have a few cumulative relative risk curves. So these will have the standard odds ratio or relative risk curves associated with them from day 0 to day 7 or focusing in on specific days. I'll also include some attributable risk functions and graphs associated with that. And then to Chris Ebai's point at the beginning of things that she hasn't necessarily explored in terms of the economic costs, I'll convert these attributable case numbers into healthcare burden, giving us a dollar amount associated with these. So if we look at the total count cumulatively across the distribution of the data, this is what the hospitalization relative risk curve looks like. We see increases in both the extreme cold and extreme warm conditions, typically peaking or starting to have an upward peak around 30 degrees Celsius and between 0 and 5 Celsius on the low end. I will also note we tested we used minimum air temperature in this, daily minimum air temperature. We tested minimum, maximum, and mean. We also looked to see how relative humidity, air pressure, and wind might be influencing these. And when we tried to put all of them together, the model just didn't work as well, partly because we had too much data and confounding issues at many times in a place like Phoenix. Minimum air temperature performed slightly better than the other temperature metrics. And so we stuck with the minimum air temperature for this. And I think we know as well from heat and physiological literature that when overnight temperatures increase, our bodies are unable to cool down, and we need that ability every day to let our bodies rest through cooler temperatures to help us manage and survive the hotter afternoons. We need that cooling off at night to make it livable. And so this is then a helpful metric to know about those hot nights in particular. Again, highest risk we are finding is above 30 degrees Celsius, and then 3 degrees Celsius for the other end. I will also note we may think 30 Celsius at night is awfully warm, but in Phoenix, Arizona, that is the average low temperature between June, July, and August. We are starting to see low temperatures in Phoenix, Arizona, pushing 37 Celsius. And by the end of the century, it'll probably be over 38 and potentially 39. So it's just going to keep getting worse. So we really need to be thinking about that far end of the curve and recognizing that there will be dates, even if there isn't a heat wave identified for that, where we're well above these thresholds. If we break this out based on sex, we see that for females, we do have not as much of a risk is what it looks like compared to males. I think we've seen this from other types of atmospheric hazards before, such as lightning, where men tend to have the higher risk, and some of that has to do with either occupational hazards or recreational choices that result in being outside more often, or poor decision-making, such as golfing during a thunderstorm, and holding a metal rod out on an empty field. So this matches in terms of what we see from other atmospheric hazards as well, even if there isn't necessarily a statistical signal that says, yes, definitively this is the case. When we break it out by ethnicity as well, we split it by white versus non-white, in part because of low sample sizes of different sub-ethnicities. And here we do see a slight statistical difference as we move from 30 to 35 for non-white relative to white. So if we combine that with the male category, we're thinking of men of non-white ethnicity. In Phoenix, that's a really large component of our outdoor workers as well. When we consider attributable risk to this, we can then break apart this relative risk and bin the data based off of the different minimum air temperatures and attribute specific numbers of cases that could be directly connected to air temperature. So with this, we broke it into cool, cold, warm, and hot. Cold and hot are your most extreme, either 0 to 10 percentile, 90 to 99 percentile, and then cool and warm are divided by the median and doing the other space. So we can see that there is some risk. 3,000 of the 86,000 cases are attributable. One may say that that's a low number. I would argue that, as Chris mentioned, that every heat death is a preventable heat death. This is also another space where there's a lot of space to prevent the hazard. We can then convert that into dollar amounts. So this uses a calculation from Stensland et al., 2012, where they gave hospital bill calculations for different hospitalization reasons, like schizophrenia, for example. For an uninsured patient in the US, the average cost for a schizophrenia hospitalization is $5,707 in 2006 USD. So when we account for inflation today, that means that our hot nights in Maricopa County are accounting for an excess of $2 million over our time period, which was 9 years. And the total healthcare burden is over $26 million that we can save in terms of hospitalization costs and Medicare bills, which would be even higher than uninsured. Or this may also, if we're addressing this issue, help us address that by reducing hospital bed loads and reducing wait times in the hospital. I have my hypotheses there, but you can also read that as well as the key takeaways in the paper. It was published in the Science of the Total Environment, and I'll stop there and take any questions if I have time.
All right. Thank you, Peter. We're going to have to move on to the next talk here. Our next speaker is Daniel Samano from the University of Miami.
How do I move forward? Big green? All right. This is okay. Well, good morning. I'm Daniel. I am a physician. I work in neurology with a focus in neuro-ICU. However, I do have a public health and a climate and health master degrees, and I'm really passionate about this. I usually have an audience where I need to convince about climate change and to include them into their daily lives, but today is kind of different. I want to invite you to think of the presentation that I'm giving today. It's about HIV populations as an example of the multiple chronic conditions that can be affected by climate, right? So I was starting thinking like, how is healthcare utilization being affected by extreme weather events and so on? And then I started like studying about weather. I have no disclosures. As we know, extreme weather events are becoming more frequent and more intense, and there are specific regions in which locations are more vulnerable. Yet the delay in mitigation and adaptation strategies is really costing human lives, right? So the sooner we can start working all together and having interdisciplinary approaches on the table, I think it's going to be better. As we heard before, Miami, it's still considered a subtropical weather, and it's ground zero. It's considered ground zero for flooding, for hurricanes, for storms, and so on. Nowadays, this is becoming our new normal. Like this was this week. On a daily basis, we're getting heat advisories, right? And yet there's still many unknowns. Like, yes, now we have these quote-unquote alarming systems, yet the population is really not aware of, or educated, or aware of what the next steps are. So as I was saying, Miami is considered ground zero because there's still people moving in, there's a big development, yet we're still very exposed to the effects of weather. To keep a regional weather portrait, as we have seen the last 30 years, on the left-hand side, we can see the extreme precipitation by decade. It has almost quadrupled, right, since the 1990s. In number of storms, it almost tripled. In number of extreme heat index days, right, it's the same. The trend is still going up. You're familiar with this. So how is climate really related to health, right? How is climate affecting the different health issues? And the way I see this is like in the last, 60 years, 30 years, even though human behavior has changed and we can adapt accordingly, our physiological reservoirs and bodies are not necessarily ready for these changes, right? The climate is changing faster than our bodies can adapt to it. So the changes are so subtle that we're really not realizing about it population-wise, right? So there are different ways in which climate is affecting health, as we have heard in the past couple of days. Through changes in air quality and respiratory conditions, tropicalization of areas in which vector-borne diseases and mosquitoes weren't supposed to live, now they're living there. So there are different ways in which climate is indirectly affecting it. And overall, it's really about like the injuries are associated with it. The increased incidence and prevalence of chronic conditions like diabetes, hypertension, hyperlipidemia. And again, like these represent a challenge because in medicine, we are not, doctors are not trained to deal with the ICD codes necessarily, right? So the data that we're analyzing, sometimes it's questionable, right? Like we really need to think about how healthcare providers need to be more involved in these and plan accordingly. So Miami is very Hispanic related, and I'm putting this as an example because we need to take into consideration the different cultural and racial backgrounds of the population we're taking care of. Here we see a pyramid of Latin America, right, where most of the people are going to be between 35 and 45. We tend to think that people in the younger ages are going to be more protective from weather events, even though they may be like outdoor workers. Yet we can see on your right-hand side the main causes of death. Since the 25 to 35 years of age is HIV. From 45 years of age up, right, is going to be chronic conditions, diabetes, cardiovascular diseases, ischemic heart disease. So we're seeing these kind of conditions in an early age of the population. The way I like to think of climate and health is in a two-way. Direct effects of weather, as we just heard, schizophrenia, right? High temperatures, exacerbated schizophrenia symptoms. Same with the likelihood of having a stroke or a heart attack. The indirect effects, however, are going to be like all these limitations for people to make it to healthcare, right? That are associated with different social determinants of health, level of poverty, household income, and so on. And even though we're all vulnerable to climate, right, there are going to be more populations that are more climate sensitive. So how do we identify them? Right? It's not the same as people living with spinal cord injury that they don't thermoregulate, they don't sweat, versus people living with HIV that tend to be African American, living under the line of poverty. So it's kind of like the same monster in terms of climate, but way different conditions and approaches per population subgroups, which kind of adds on a little bit more complexity to the situation. Specifically talking about HIV by region. So finally, we see a map on population, not necessarily on climate. The southeast of the US houses 45% of all the people living with HIV in the US, right? And that's 30% of all the population. This is 43% of all the new, like the incidence is 43% in these areas. Hispanic, Latinx represent 18% of the US population, and 27% of all the new HIV cases. These populations are gonna be living under the line of poverty, lacking health insurance, and a high HIV prevalence. Now, why is HIV important, right? Because if people don't make it to their healthcare at one point, okay, they may get their appointment 6 months, 9 months after. So their viral loads increase and the transmission in the community increases. Therefore, there are more indirect effects, right? Miami, it's one of the highest transmission rates in the US. And just for you to know, the goals for the CDC and worldwide are to have like 95% of awareness, 95% on treatment, and 95 controlled conditions. Yet the numbers are still low, and this is just for Miami-Dade, which is not as bad as other parts of the country. HIV does have a lot of inequities, right? By racial and ethnic groups, we can see African American, 40% of them, Hispanic, 25%, white, 25%, which is kind of representative to the population that I'm going to be talking about in the clinics that we serve. In Miami, 70% of the population living there is going to be Hispanic. 86% of them are going to speak Spanish. And that's why it is important to put into context these kind of things when we are also going to make an approach on climate. There have been a few, unfortunately, there are not that many studies, but there are a few studies doing time series analysis to merge clinical data and climate data. This is one of the papers, oops, let's go back. This is one of the papers that we published about that, which was this one. We basically included hurricane season from 2017 to 2019 in Miami to assess how was the clinic no-show rates, right, in different weather events. For heat index, we defined what was extreme, and I'll get into that later on. But basically, we saw that there was a no-show in a heat index above 100, right, up to 14% relatively associated to climate only. Precipitation below the extreme, 16%. Precipitation above the extreme, 13%. No-show, right? So we did a follow-up study, including 5 years, 12 months of the year, only in the operating hours and operating days of the clinics. These clinics are in, let me show you, this is Miami International Airport, this is South Beach. In the middle, we see the clinics, right? They look like this. This is the data for 7 different clinics looking for all genders and all population living with HIV in Miami. People come from like 3 hours away to these centers. This is aggregated data, and the data from climate is from the Miami International Airport Station. So we define what local extremes are, consider 30 years of data, and any value above the 90th percentile was considered extreme. So for Miami, extreme is going to be a value above 101.5 for extreme minimum temperature. This is heat index, by the way. For minimum temperature is going to be 59, and for precipitation is 2 inches, 0.1. So we know this, this chart from NOAA, and where they give us like different potential dangers to the body, right, if you're exposed to these different temperatures. So extreme for Miami, lands somewhere here. And keep this in mind because later on I'm gonna bring it up. Our population, as I was saying, is representative from Miami racial and ethnic groups, where we have 43% of them being Black, white, 31%, and Black Haitian, 17%. We have a strong Haitian community in Miami. In the study period of 5 years, there were 87,000 scheduled visits. Important to characterize, these are scheduled visits, not necessarily people. There may be some people having to come multiple times a year. Total attended, almost 50% of them. So the analysis was done around this number. In this study time, in this study period, there were about 5 months of extreme heat index, about 3 months of minimum temperatures, and 3 months of extreme precipitation. And there were around, in numbers of extreme heat days, there are about 9,000, 9,700 scheduled visits. So when we see the results from racial and ethnic groups, right, first of all, the overall picture is as expected, as the heat index ranges between 95 to 100, or above, the later two are going to be extremes. We can see some changes already associated to heat, right? When it's 90 to 95, it's about 5% decrease in attendance, no show, right? As it becomes more extreme, 8% and up to 12%. Interestingly, though, by racial and ethnic groups, it behaves kind of different. If we see black, right, in extreme, right, that's up to 18% and 9% in extreme heat. Yet, when we compare to black Haitian, and this is statistically significant, by the way, they do attend more, right? It's not that much here. It's 3%, right? But this kind of brings up the conversation as of, well, initially I thought like it would be kind of like applicable to everyone coming to the same clinic, not showing up, right? But it may not be like that. It may be more like there are cultural, environmental, depending on the neighborhoods where they live, they may be more, I don't know, flooded related things. There may be more cultural things. And this happens when you ask people in the clinic, like, hey, it's gonna be a hot day. Some people are gonna tell you, oh, they're not gonna show up. And some people are gonna tell you, oh, it's gonna be full. So I don't know if it is because they don't have AC at home and they come to clinic to take care of that, but sometimes it's different. So there's still a lot of unknowns. Coming back to what I was saying is, initially I was thinking that extremes were any value above these we were gonna see bigger changes. We do, right? But we are seeing changes below the extremes. And then this brings me to this idea of this analysis was done for the previous 30 years, right? But we're living in normality, what used to be extreme 30 years before. If we use the 30 years before, right, our number of days increased considerably. I'm asking this openly, and by the way, this is dry bulb temperature, this is not heat index, but I'm asking this openly because I'm trying to understand, right, like how the future, the past temperatures were and how the future temperatures are gonna be in this dynamic relationship, so we can address the present and actually guide the future, right? I am not really sure how to interpret these increased numbers. And I'm saying this because this is important when we bring this up to, I'm just gonna fast forward, when we bring this up to healthcare providers, how we sell these ideas and bring healthcare providers to the table, right? They wanna know cost effectiveness analysis. They wanna know how much these more days, right? How much these increased risks are really associated with more numbers and potential solutions. So these kind of studies are really helpful. Limitations is aggregated data. We really need to get into the nitty-gritty details of it doing it at the individual level, but of course guiding public health policy, right? Bringing the conversation to healthcare systems and costs. Sorry, I'm running out of time, so if you have questions, happy to talk down the line. Thank you.
Thank you, Daniel. Yeah, we're going to go ahead and move on to the next speaker. Our next speaker is Tim Zhang from PNNL.
Hi, thanks for introducing me. My talk is kind of a black sheep of the session. I'm not sure why I got placed here. I think I probably misclicked when I was signing up, but I guess I'll do my best to keep you engaged anyway. So let's start with a bit of background on the UTCI, which is the metric of heat stress that I'm going to be using in this talk. You can think of it as a feels-like temperature that depends on air temperature, obviously, but also humidity, wind speed, and mean radiant temperature, which itself depends on the amount of solar radiation and long-wave radiation that's received, that's absorbed by somebody. And long-wave temperature, in turn, depends on the surface temperatures of the surroundings of a human. So with that out of the way, some background on extreme heat. It should come as no surprise to people in this room that extreme heat is going to be more prevalent and more intense in the future, with impacts on morbidity and mortality, impacts on productivity, also on the infrastructure, as we saw yesterday, air pollution, as was addressed in a talk and posters yesterday and today. And this could lead to some serious consequences, such as concurrent extreme heat and blackout events, which are very, very dangerous. With that in mind, that means that we should be doing projections of all of these events, all of these consequences for extreme heat events. And there are projections for example, AC energy use, for mean radiant temperature, and for the effects of humidity on climate effects of humidity on thermal comfort for future summertime conditions, but for heat waves, this is lacking. One possible reason for this is that to capture the effects of extreme heat and the small-scale effects of extreme heat, it's better to use dynamical downscaling, which captures the processes and uses physics-based relations, versus statistical downscaling, which those other studies used in some form or another, which is not suitable for extreme events. The final piece of the background puzzle here is that most studies that I've seen in the literature address a single outcome, that is either air temperature or radiation or air quality or energy use, but in this study, we aim to study multiple outcomes in one coherent framework to facilitate comparison. And you'll see what I mean by that later on. So to do that, I simulated 1 year return period, week-long extreme heat events for 3 cities with wildly contrasting climates. I did so for 3 cases, for a start-of-century case and 2 end-of-century cases for different climate scenarios. And I analyzed 2 events, that is 2 heat waves for each case and city. I did so using this modeling framework, which at the core is using WRF-BEM regional weather and urban canopy model to downscale either reanalysis or projection climate data down to 9 kilometers, 3 kilometers, and then 1 kilometer. Then I used output from WRF-BEM as upper boundary conditions to a microscale radiation model called Tough Pedestrian, which simulates mean radiant temperature at the meter scale for, and then I combined that with outputs of air temperature, humidity, and wind speed from WRF-BEM to get projections of pedestrian heat exposure in the form of the UTCI for both contemporary and future projected climates. I also extract building energy use and tracer concentration directly from WRF-BEM. So some more details about WRF-BEM. I used version 4.3.3 with the urban canyon and building energy model, as well as an implemented basic tracer model, which has no physics, which means there's only dynamics and dispersion in that model. And we also assumed ground level emissions that were proportional to urban fraction. As for the Tough Pedestrian model, its greatest strengths is that it can accurately and physically project or predict surface temperatures at the meter scale in urban canyons. So with that, we get highly accurate meter scale long wave radiation and therefore mean radiant temperature on pedestrians. We placed pedestrians at 4 street locations that were 2 meters away from buildings in a regular urban canyon. And the locations were chosen because in modern cities, pedestrians don't spend too much time in the middle of the streets. So with all that background out of the way, let's look at some results. What you're looking at here is AC energy use in Phoenix for the different climate scenarios. The black lines indicate the start of century climate, and the blue lines, or the red lines, colored lines, indicate end of century climate. The solid lines indicate start of century urban development and population and density, and the dotted lines indicate end of century urbanization. So what we're finding is that by the end of the century, we expect AC energy use to increase in all cases, but that most of this increase is due to the urban development and population increases, i.e. about 70% during heat waves. And that's roughly comparable to what Tawari and others found for typical summertime periods. Now, moving on to the increase in UTCI and heat stress, what we find is that for all cities, all times of day, all climate scenarios, it's expected to increase, as we suspect. And the breakdown of that increase is that most of that increase is due to increases in air temperature. However, increases in radiation, and which is primarily attributable to increases in surface temperatures in urban areas, do play a role, as well as the effects of humidity in Toronto under RCP 8.5 especially. Now, given the increases in UTCI and as well as AC energy use, how can we adapt to that? Well, there's been some commonly proposed heat adaptation infrastructure. For example, cool roofs, rooftop PV, green roofs, street trees, and reflective pavements. And so we simulated these strategies in terms of both the microscale and the local scale, that is both in tough, pedestrian, and wharf. And here's what we found. In terms of heat stress, so let's back up a moment. What you're looking at here is the day-type average UTCI for a typical kind of intensely developed district of each city under 3 time periods, start of century and 2 end of century cases. And what we find is that cool roofs are fairly effective at reducing the UTCI by a degree or 2. However, street trees have the largest effect on UTCI throughout all cases. And we might be wondering why street trees have that effect. Well, we broke it down and found that it's mostly actually the shading effects of trees that are doing most of the work here for all cases. And however, street trees do transpire. That is, they convert sensible heat to latent heat. And therefore, they can reduce the air temperature as well, especially in Phoenix and in Toronto. In terms of AC energy use, again, street trees and cool roofs are quite effective at reducing it. However, if we consider the amount of electricity that is generated by rooftop PV, then we find that rooftop PVs are more than able to completely offset AC energy use on average. However, I should caution that this is just an average, because at peak AC energy use, we find that PV roofs are quite unable to mitigate that. And the reason for that is because peak AC energy use occurs often fairly late in the day. So instead, we find that strategies such as green roofs are effective at reducing peak AC energy use if there's no storage that can be that's available for electricity generated by PVs. Finally, we looked at the effects of these adaptation strategies on the dispersion of pollutants. What you're looking at here is trace residence time, which is a measure of the inhibition of pollutant dispersion in the city. And what we find here is that while all heat adaptation strategies do tend to increase the tracer residence time, mostly because they lower the planetary boundary layer height, street trees do have the greatest effect. And that's because, in addition to lowering the boundary layer height, they also actually directly inhibit the flow in the urban canyon. So to synthesize, we can put the effectiveness of heat adaptation strategies in terms of heat stress on the x-axis and in terms of AC energy on the y-axis. And we find that the heat adaptation strategy that's at the top right corner the most often is the combination of street trees and PV roofs. So that implies that that may be an effective mitigation strategy or adaptation strategy, excuse me. So to conclude, in extreme heat events, heat stress and energy use are projected to increase by the end of the century. We found that street trees can reduce outdoor heat stress to start of century levels, but if they're implemented, we should be cautious about ventilation. And we found that PV roofs can offset AC energy use, but not at peak cooling demand. I'll skip this. And I'd like to thank our funders, as well as the Digital Research Alliance of Canada, for over 70 core years of CBU time in the study. Thank you.
Thank you, Tim, and great job coming in on time. But given that we're running a little bit late, I think we'll ask anybody with questions to catch Tim in the coffee break, and we'll go ahead and move on to our next speaker. Our last speaker is Jeremy Baudreau from Water, Earth, and Environment Research Center in Quebec.
Okay, all right. So last talk before the break. So I'm going to try to be quick, but be enjoyable. So today I'm going to talk to you about some of the research I've done in my PhD program in Quebec in collaboration with Health Canada and also Quebec National Institute of Public Health. We're going to talk about a lot of things that have been seen in the last couple of presentations. So health impact, economic impact, data science, and climate change. So after these few days of workshop, we all know that extreme heat has major impact on various sectors and that these impact will be, of course, amplified by climate change. Just talking about the death toll, we've seen in France and in Europe like 15,000 deaths in 2003 and 70,000 across Europe. In Quebec, from where I'm from, we're a northern province, so maybe we think we don't have problem with extreme heat, but in 2010 and 2018, we had these two major heat waves that resulted in nearly 200 to 300 deaths. And the heat dome in 2021 in British Columbia, so western part of Canada, resulted in nearly 700 deaths. And in 2023, we had these major wildfires in Quebec, and you probably heard about them because of the air pollution that went through New York, but this was also a very extreme summer. So we've seen with the presentation of Christopher that we wanted to predict these events in order to reduce the consequences now, but also in the future, knowing that these impacts will be higher. So we think that using data-driven data science approaches that include both machine and deep learning models, but also more classical statistical models can be used to that end. And today I'm going to present to you two applications that we've done in the public health sector. First one is predicting the heat-related health impact, and the second one is quantifying both the historical and future health costs of extreme heat. So as I've mentioned, we've done the work in Quebec because it's hard to get data across Canada because of provincial jurisdiction. It's a 8.5 million province, and it's divided into 15 health regions. That's the spatial scale that we've looked at. It's a good scale for statistical power, but also relevance for decision makers. So in the first application, we've considered machine and deep learning models. These models include penalized regression, such as the lasso, ensemble tree-based models, such as random forest and light gradient boosting, and also deep neural networks, such as the multi-layer perceptron, which is a vanilla feed-forward neural network, but also more complex recurrent neural networks, such as the LSTM. In the second application, we've used models from the statistical or environmental epidemiology field. So if you work with heat-related health impact, you've probably heard a lot about the distributed lag nonlinear model. It's probably the state-of-the-art model. So we fitted this model for each of the region, but also used the multivariate meta regression to pull the results. And as you see, for different goals, we have different approaches. But for us, we see that these two approaches are both from the greater data science family because these are two data-driven approaches. In terms of the data that we use, we've looked at mortality, but also various morbidity indicators, so hospital admission, ED visit, ambulance transport, and call to a health hotline. These were all cost indicators. We're going to look at cost-specific in the future part of the project. We mostly work in the general population, but in the first part, we also look at the more vulnerable population, so the elderly population. In terms of the predictors in the model, so for the machine learning model, we just put everything in the model. So it's very simple because we just want to do predictions. So we put a lot of weather variables, so maximum, minimum, mean temperature, humidity, humidex, humidity variables. So we just put everything in the model. We put the temporal trend, we put the socioeconomic variables. And of course, these models, by construction, they consider the different interaction between these variables, for example, temperature and humidity. On the second part, we need to be a bit more cautious about what we put in the model. So for the exposure variable, we use mean temperature. We also tested other temperature metrics, such as the humidex, the dew point, maximum, minimum temperature. We didn't see that much of change. We controlled for relative humidity, temporal trend, and also air pollution for the region for which we had the data. And after that, building the models, we use the socioeconomic variable in the meta regression. So it's a different setup, but at the end, it's the same, pretty much the same predictors. So I'm going to show you some results when we build our prediction model for the daily heat-related health impacts. So we've looked at very classical performance metric in the machine deep learning field. So first look at the R-square based on out-of-sample year of data, so data that the model have never seen to predict the different health outcome based on the different model. And what we can see here is for most of the morbidity impact, we had R-square above 60%, so that was pretty good based on the fact that we're on out-of-sample data. For mortality, it was very low. It was just about 10%. And the best model were mostly the deep neural network models, so MLP and LSTM. But we also have seen that some ensemble tree-based model were sometimes the best, but we never seen the last one model, which is the baseline model, to be the most performant. And then we looked at other criteria. I'm just going to show you one more here, which is the mean absolute error. And it's the same behavior across the different model, across the different health outcome. So we're done. We know which models are the best. But that was not good enough for our partner at Public Health. And what we wanted to know is, these models are maybe good during summer period, but what happens during extreme heat events? And we were lucky because we had one major heat event in the out-of-sample set, which was the 2018 heat wave that I talked about earlier. So we looked how the model would work when they see this heat wave, even though they were not trained that much with heat wave. So in the black line is what was observed during the heat wave. So the heat wave period in gray, 3 days before, 3 days after. The different colored line are the prediction by the different model across Quebec for mortality and then for the hospitalization. And we've seen that the model that were identified previously, the deep neural network, were not that good because the only model that predicted the increase in mortality well was the model in red, which is the light gradient boosting model. And that was kind of surprising, and it shows us that we cannot only rely on performance metric from the machine and deep learning field. In terms of hospitalization, we didn't see that much of an increase during that heat wave. Mostly the level were at the same level than 3 days before. We also looked at ED visits, and some models wanted to have an increase, but in fact, we didn't see that much of an increase in the observed value. What we've seen is increase in ambulance transport, especially at the end of the heat wave. And again, the model in red, which is the light gradient boosting, was the one more closely able to model this impact. And then it was followed by the green model, but the other model were really much off track. So that shows us a different perspective on how to validate these models to do prediction. And we didn't have, and we've also looked at another heat wave that occurred in 2021, and that's pretty much the same result and also the same result for the other health outcome that we've looked at. So I'm going to move on to the second application with different model, but to do something different, which is quantifying the heat burden and associated costs. So for that, we wanted to develop exposure response function, as Peter has already shown, by using the distributed lag nonlinear model and also the meta regression. So we have 15 regions, we have 5 health outcomes. So do the math, it's 75 exposure response function that we needed to develop. So I'm just showing you one function here. And with this function, we can derive the heat attributable number, which can be mortality or morbidity. So when we do the overall total for Quebec, we see that yearly we can have approximately like 500 deaths, 225 hospitalization, and so on. And these results were already published. So that was only for the historical part, and we don't have any economic information. So we went a step further, and we included climate projection based on ensemble of climate models and also demographic projection. So that was for the future burden, and then we needed also to incorporate the cost. So we developed a framework in which we can use the inputs from climate model, the DLNMs that were already built, then compute the heat-related numbers for the historical and future period, and then compute the direct costs, which are the healthcare costs, the indirect costs, which are related to absenteeism, so loss of productivity, and then intangible costs, which are loss of life and loss of well-being. And then with that, we can compute the total historical and projected heat-related impact for 2 scenarios, so SSP2 and SSP5. So just one slide of result, because I think it's pretty much self-explanatory. So we see in black, there is the current cost for the direct component, indirect component, intangible, and the total. And then in blue is when we just look at the climate in 50 years based on SSP2. So we see twice more costs. And then if we also increase the population, so this is in purple, we'll see greater exposure to heat, so even more costs. And then when we go to a higher emission scenario, so SSP5 in orange, the cost continues to increase. And when we include the population, it's, well, the worst case. And these increases are up to 4-fold, depending on the cost category. So the numbers here are pretty much like 15 million in the historical period, going up to 50 million yearly in Quebec. So there's a strong case for mitigation, because if we reduce the greenhouse gases, of course the cost will be reduced, but then also adaptation, because we've already have a lot of costs in the historical period. So we need to put in place more adaptation measure. And these projections are made without any further adaptation or other hypotheses. It's just increasing in climate and increasing in population. So the key messages is we could leverage machine and deep learning for one of the first time to predict different heat-related health impact. And we've done that for all regions of Quebec. And we've obtained the best result with deep neural network through all summer with classical performance metric. But then when we look at heat wave, there was only one model that was pretty much accurate, which was the light GBM. We then used statistical model more from the environmental epidemiology field, and we were able to quantify the historical, but also the future burden and associated costs. And we see that this burden can increase up to 3 to 4-fold in 2050 compared to 2000. So we think that data science can really provide a cutting-edge tool for climate adaptation and also provide new economic evidence that can be used in cost-benefit analysis. And even though the application that I've presented are in the public health field, I think they can also be leveraged in other sectors. The next steps for the study are, of course, to study some vulnerability factors, because we've worked on all cost data, all population, and we want to take these models at a micro scale, so looking what's happening in the neighborhood with urban heat, island, etc. So that's next step, and we need to have individual data for that. So we're going to look at that in the couple of next year. Thank you, and have a good break.
Thanks so much, Jeremy, for the interesting talk, and let's thank all our speakers again.